presenting to our group. We're so blessed to have her be willing to join us. So we're going to turn the time over to her and let her get us started and tell us how she wants us to interact and just be real happy that she's here.
Oh, you've got yours. I got you.
I do. Well, thank you. I am Allie. Really, just plain Allie, unless you're in a whole bunch of trouble and then you get my whole name and all my titles and all of that. So just don't get in trouble and you don't have to remember any of those. I am not so organized that your questions will throw me for a loop. In fact, I have virtually no notes. I have an email from Joyce telling me that she talked to folks and there were a couple of questions and could I talk about that? And then we'll just do what you want to do. I need you to know that our oldest granddaughter is turning 11 and her birthday lunch was today. I left to get here on time, and so when we get done, I'm going to go back and hope that there might be one small slice of cake that someone hasn't yet consumed. So let's look at those things that Joyce asked me about. And I think probably it's best if we start with drugs for the condition for which you need. And yes, there is a new product-ish, the Crexont. I don't know that it is significantly different, right? It's the same base chemicals as Cytomel from all of those decades ago. And to hope that it does something dramatically different doesn't really fit pharmacy very well. It does do things slightly differently, but it is more how long it lasts that is different. So if you were hoping, oh good, finally somebody made a drug that I can take and eat my bacon, lettuce, and tomato sandwich at the same time without worrying about the protein, I'm sorry, that's not what they made. Because the protein interaction in your belly is the protein interaction with the chemicals in the prescription drug. And it really doesn't care if we put it in a tablet or a capsule, and it really doesn't care if we say it's immediate release or timed release. When that chemical encounters protein in your belly, it says, oh, I know what this means. This means I am not supposed to get into this patient's bloodstream. So if you have been reasonably careful about avoiding a protein meal when you are scheduled to take your drug, stay careful. For those of you who are like, yeah, you know what? I'm just gonna let them raise the dose. I am gonna have my bacon. When I have my bacon, I'm gonna take my tablet. When I take my tablet, just have them raise the dose. That's okay. That is certainly an option. I do ask though, don't stop the bacon, right? Because we base the dose for you on how you respond. And if you are traditionally creating that protein drug interaction in your belly, I get it, I do. I can't remember the last time I said no to bacon. But the issue is, I can't afford for you to make huge changes in your life. Because then that makes big changes in the amount of drug that you absorb. And if you make changes in the amount of drug you absorb, then you respond differently. And I wonder, what on earth did I do? Because I may or may not remember to say, have you changed your diet? It just isn't one of those questions that we ask in the pharmacy all that often. There are just a handful of drugs where that matters. And so sometimes that falls down my list of questions to ask. But I do think that one of the things I wish that someday I could stand here and say, I think we found the cure. Today's not that day. I wish that someday I could stand here and say, we have created a vaccine that is going to prevent this disease. Today's not that day either. But because of folks who have had Parkinson's disease and their contributions to research, in addition to everything else, we have the first new drug to treat schizophrenia in 32 years. And the reason that your group and that people like you are vital is because when we think about how does carbidopa-levodopa work, why would we put those two things together, knowing that only one of them can get to your brain and help? So why would I add this second thing? And we find that adding that second thing changes some of the side effects. And it changes how the drug works. And it's that theory that we can make one drug that goes to your brain and another drug that can't get there, and put them together to protect the brain without poisoning everything else, decreasing all the side effects, making the drug that gets to their brain better. And chemists, pharmacy chemists, not me, you really do not want to turn me loose in the chemical laboratory. I survived organic chemistry a few years ago, and I don't want to go back to the lab. That's not where I'm good. But I have colleagues who are fabulous at it. And they found two drugs. One of them will amazingly treat schizophrenia, and the other one blocks the external outside of their brain side effects. And had it not been for all of our research in the Parkinson's disease, we never would have this brand new drug. And for some folks with schizophrenia, this is going to change their life. It's not a cure either, but some folks suffer so badly from side effects that they can't chew. Some folks suffer so badly from side effects that they can't walk standing up straight. And perhaps we can help all of those folks because of the incredible dedication of people like you, right? And it's not just people with the condition, it's people who care for them and say, I wish this was better. I wish this was different. I want something. And that's sort of how scientists make a decision about what are we going to do next. They truly don't just sit around mixing chemicals together to see what happens. Perhaps 60 years ago, they may have done that. But now, It's really cool. I've watched them do it. They find the receptor in your body, right? The light switch. And you've got a couple of light switches you want me to shut off. All of those nervous twitch light switches, you want me to shut them down. And my colleagues in pharmaceutical chemistry know exactly what that light switch looks like. And they know exactly what the chemical that can flip the switch has to look like. And they sit down at the computer and say, okay, computer, show me how I can make something shaped like this. And sometimes the computer kicks out things that are completely, totally poisonous because we forgot to tell it not to do that. And sometimes the computer says, I don't know how. I can't make something that shape. And sometimes it says, well, here is the shape you want. And when they try to make it then in the chemical laboratory, they can make it and it lasts 2 or 3 seconds. And then it falls apart. So they have to start again and say, all right, now we need to create something shaped like that will protect the something shaped like this so that it lasts longer than 30 seconds, right? And all of those incredible incremental steps are going on right now. And one of the most exciting and frustrating things about doing a program like this is tomorrow may be the day when they find that new chemical and you will all think to yourself on Tuesday, why didn't she tell us about that? Well, because today I don't know about it. And tomorrow we may all know about it. But I can tell you this, you will not hear about it first on Google. You will not hear it first on Facebook or Twitter or X or Instagram or Snapchat, or you will hear it first from the scientific literature. And I suspect that most of you do not subscribe to the New England Journal of Medicine. I don't either. I actually trust my librarian to give me the few articles a year because I think that mostly it's a little dry. I do subscribe to the American Journal of Pharmaceutical Education. Probably not going to show up in there first. One of the chemists in my College of Pharmacy will probably tell me, hey, watch for this. The article will be out within the next 10 days. But I really think that for a number of you, you're going to at least get to read about the next great chemical. I really believe that. We learned so much. COVID was horrible. We killed 7 million people. I still can't completely wrap my head around that number. It was as if everybody in Nebraska died 3 times. Yeah, wow. But because the whole world was sick and dying, we learned new things about creating, in this case, the COVID vaccine, but it was the theories, how can I use my computer to show me what the chemical has to look like? And then I can go try to make it. Well, we didn't just throw all of that knowledge away as soon as we said, oh, cool, we got a vaccine that works, now we can move. No, we said, look at what we learned how to do. Let's use it for things that matter, like Parkinson's disease, like congestive heart failure, like chronic kidney disease. And so suddenly we are doing research in a completely different way than we had ever been able to do it before. And the next time you get a hankering for country western music, thank Dolly Parton. She gave over $1 million to Vanderbilt University. And a big piece of that was the development of the computer technology to make all of this work. And she just gave it away. And because of that, Vanderbilt University just gave it away. And everybody in the science world can now use some of that technology. We're not quite at the point where I get to say, hey, it worked for this condition. But I know that there are people working on it who have never, ever worked on it before because they just weren't sure how. Well, now I think maybe they will be able to figure that out. I'm looking here to see, yeah, I didn't wear the right glasses. Oh, another of the questions that came in was, tell me about nicotine patches for treating the condition or treating the annoying pieces of the condition. And I understand the desire to find something. And I understand that if you read a data bit, and the data bit that I am referring to is smokers test positive for Parkinson's disease less frequently than non-smokers. That's what we know to be true. Am I ever going to recommend that somebody develop a nicotine addiction to avoid Parkinson's disease? And the answer to that is absolutely not. Lung cancer is horrible. Mouth cancer is horrible. So no, I'm not going to recommend that. But did we, in some massive database, identify, oh, it kind of looks like smokers don't get Parkinson's as often? Yeah, we identified that. That doesn't mean it's a good thing. It just means it's a thing. Smokers don't get. So somebody said, well, what happens then if people with Parkinson's try nicotine? And some of you went, well, that makes sense. And some of you said, wait, no. There's nothing in any of that data that says that smokers do better when they get Parkinson's. That wasn't it at all. What the data said was, it looks kind of like one of the non-smokers get Parkinson's more often. Okay. That doesn't mean once you get the disease that you should start smoking. And it doesn't mean that once you get the condition, you should start wearing nicotine patches, because nicotine is not harmless. You can actually become dependent on it, even if you just chew nicotine gum, or if you just wear nicotine patches. And it changes sleep. And it changes the way things taste, even if you never put it in your mouth. And sadly, it doesn't do anything to treat Parkinson's symptoms. Because nobody ever said it could. We just took this one lonely data bit that said folks who didn't smoke were more likely to have Parkinson's disease. And somehow we drew this tortured line and the science didn't make sense when you said it out loud. I understand, man, let's give it a try, because somebody had the idea. But when we tested it, it turned out not to be I wonder, using that sort of. I'm assuming that I have a room full of lots and lots and lots of Cornhusker fans, true? Okay, so if I told you that Colorado Buffalo fans got Parkinson's less frequently, how many are you gonna cheer for them? Oh, okay, because, good, so you got that one, right? No, not gonna happen, can't do it. I completely understand. But for me, that's really not different than the folks who have attempted to try nicotine outside of an organized study. I can tell you that there have been organized studies. There have been studies of smokers. There have been studies using nicotine patches on your arm, on your back, and on your thigh. There have been studies using nicotine gum. And in some countries, there's this weird little mint thing, kind of like Tic Tacs, if you will, that is nicotine based. And in one of those countries, they did a study where people just sucked on those. And I think it was like once an hour while you were awake. And it didn't do much other than they complained about changes in sleep. Some of the patch people complained about skin problems, their skin got dry or the patch got itchy or whatever. And the people with the nicotine mints, that's not a good word, but the nicotine dissolvable thing, they complained that food tasted different and that they felt the need to brush their teeth all the time. And those sorts of things. So, but that's a really cool question, because I hadn't looked at the initial data, goodness, for years, right? I've been at this for a while. I remember when a scientist from the medical center decided it was drinking well water that was the big risk factor. And he was gonna do this huge study on people who drank well water as opposed to people who drank city water. And the question was always, okay, so what's so different about the water? Is it the fact that cities pour chlorine into theirs to make sure that there's nothing infectious in it? Or is it that there are some heavy metals that show up in well water that we don't allow in? And it turns out it didn't really matter. But it was an interesting theory. It was an interesting few years of study. And every time somebody has one of those ideas, you think, oh, I wonder if this is it. I wonder if we are going to learn something. And so please, don't ever stop asking the questions, because it's entirely possible that nobody ever thought about nicotine patches, or nobody ever thought about, gee, I wonder about the source of your water. I'm not sure where my water came. Let me look here. Oh, they got it out of the sink in Des Moines, Iowa. Well, really, they're not even gonna lie and tell you they got it out of the ground. They got it out of the sink in Des Moines, Iowa, and that's okay, because it tastes good. So if it turns out that it's water in Des Moines, Iowa, but it probably won't. There was also then some questions about other things. One of them was using botulinum toxin to, in essence, intentionally paralyze certain muscles. Not big muscles, but pieces of motor muscles. And we know that we have, initially you said botulism, I said dead. Because what happened if you consume food that had botulism, you stop breathing. and you stopped breathing because all your muscles got paralyzed and you couldn't breathe. Okay, that's not what we want. But then in science, we discovered pretty quickly that you can purify that. And so we use botulinum toxin to treat things like overactive bladder. If the muscle around your bladder, your detrusor muscle, just spasms, then like every time you cough or sneeze, you wet your pants a little bit. And that's not a good thing. And so we figured out that that worked. And we have discovered that certain children with spastic cerebral palsy get rid of some of those spasms if we use botulinum toxin to paralyze little bits of muscle. Could that help if you have a particular muscle group that spasms and acts up more than others? Could we just paralyze it without permanently damaging the nerve? I mean, frankly, we could go in with a cautery and just burn the nerve up at your spinal cord. The catch is it's never coming back. When we use botulinum toxin, eventually it will wear off and that nerve will then regenerate and start sending signals again. But there are some studies that are saying if we are really careful, and hold that up, if we are really careful and we have guided imagery, which means that they're going to use a radioactive dye to light up all your blood vessels. And then because it's radioactive, I can see it on my screen, it lights up differently. And then I can find the nerve I want and I can inject drops of botulinum toxin that folks with severe drop foot, maybe we can help you walk more easily. And there are a couple of other issues that they are looking at. If your challenge is that your head bobs, we have discovered we're not going to do that because the muscle that I need to paralyze to make that stop is so close to other things that I cannot afford to paralyze. I need you to be able to swallow. I like it when you can speak. I like it that you can see. And I know it doesn't feel like it, but that tiny little space where I would have to put those drops of botulinum toxin is so close to other control centers that right now I can't stop this one. I'm not, we don't have the science that teaches us how to do that. But the foot drop, we may be good at. If you have a one side that is considerably worse than the other, we may be able to stop some of the spasms that interrupt your sleep. Understanding that botulinum toxin can spread for up to 90 days after injection. Which is why the people who use it for wrinkles, this lady can vouch for this. Apparently I do this a lot because there is a crater between my eyes and my muscles just kind of let it be there. Or it's a big old wrinkle, depending on how you want to look at it. I fill that with botulism and make that line go away. Yes. And it may be great for a day or 2 days or 89 days. And then I might go blind. Because remember, it spreads for up to 90 days. So what used to be everybody and their dog needed to run get Botox for this or that or the other thing. We're not doing quite so much of that anymore because we discovered, oh man, those first couple days, that's amazing. That's just what you wanted. But be careful. When I'm doing ankles and feet, even if it spreads, we haven't yet had any significant number of people get to the knee. So it doesn't really change much, which gives me more confidence in taking the risk and explaining to you what the risk is. If you have hemiplegic movements that stop you from sleeping, I am much more confident treating half your body if I'm trying to make something stop, knowing full well that you have the other half of your body. And I'm gonna get most of it back in 90 days. Even if I did the Botox thing and went blind, I would probably be able to see maybe in time to watch the Super Bowl, but probably not in time to watch anybody open Christmas presents. Those are sort of the things that we need to be really careful with. And then there was a question about Ozempic, but I don't know what the question is. So if somebody can guide me to what do you want to talk about with Ozempic, I would be thrilled to do that. I just got to admit, I don't know what I'm talking about. I don't know if the question has to do with heart disease. I don't know if the question has to do with diabetes. I don't know if the question has to do with Serena Williams lost a whole bunch of weight. I don't know what the question was about. I can tell you about the SGLT1s if you want to. I'm just sort of, whatever you want to talk about is why I'm here. Yes, sir.
Encourage what AI is not being involved in.
Oh, man, the question is, where does artificial intelligence fit into our whole discussion? And we get asked that on a number of different levels, almost once a week. My first comment is, what does artificial intelligence mean? And I'm not really trying to be a smart aleck, it just sort of happens. When you're good at something, it just shines right through. If you are saying, do I use Google Translate to read papers written in English, in languages that are not English? Yes, I absolutely do. And a bunch of my work is currently mirroring things that they're doing in Italy. So I will pull up the manuscript in Italian and say to my computer, turn this into English. And I will tell you that I trust that my computer translated it correctly. Would I ever just trust my computer if I was going to directly use that on a patient? No. I would call somebody who spoke English and Italian and say, is this really what it says? And I think that's how most of us would do it. When I am saying, computer, I need to build a chemical shaped like this, show me my options. I think that's probably what you would think of as artificial intelligence. And that's where sometimes it shows me something that's a poison, because it will fit, it'll be perfect, except for the fact that the patient will die. And that's why you have to have a human say, no, that's not what we do. We know that we need to have a real live practicing scientist between the AI and our patients. Do I rely on the computer to help me identify critical versus annoying? Yeah. But I told it what to look for. I said, if the patient has this, or this, critical, show me that first. Then show me this group, then show me everybody else. So that I look at people in the order that I need to look at them, so to make sure that nobody dies. It's really no different than the little guy in the military with the clipboard who is running around saying, hey, this one's bleeding, this one's not breathing, which one gets to go first? It happens when the ambulance comes upon a significant accident. Which patient needs us the most? And I do in fact rely on my computer when I have very limited resources. I have 13 people who need something and I have 2 of them. And I have to decide which 2 I say yes to and which 11 I say, sorry, I don't have enough. And because when I didn't have an emergency decision to make, I took the time to say, this is the most critical thing. This is next, this is third, this is 15th, and write them. Then I can say to the computer, okay, figure this out for me now. Understanding that it will kick, if I gave it 15 things and I didn't tell the computer about all 15 of those things, it will kick that patient into a different file and say, you didn't give me all the data I needed. And so I still have to do that by myself. But yes, I think we are learning how to use computers to work more efficiently, but we certainly don't let them do it by themselves. If you were a 2001 Space Odyssey fan, we still don't have help. I promise. I promise we don't. Not yet. Yes.
I wanted to know, is Parkinson's autoimmune? I mean, I'm just reading about it. And
Is Parkinson's, well, what, I don't know what happened. Is Parkinsonian disease an autoimmune condition? That is your body attacking itself because something happened that made it not recognize that you were you? I'll explain in a little. At this moment, we don't think so, because I have drugs that stop that. Right? I can use adalimumab to say to a patient with Parkinson's or with psoriasis, stop fighting yourself. And their skin gets better, and the itch goes away, and the arthritis improves. And I can't stop Parkinson's using the same technology. Does that mean that there's not another kind of autoimmune that we haven't discovered yet? No, it doesn't mean that at all. It means that everything we know about autoimmune conditions and immunology right now says that's not what this is. The other thing is there's a little piece, a protein in your blood called C protein. Are we clever or what? And elevated C protein says something is inflamed. It may be micro-inflamed. You may not feel it. It may not hurt, it may not feel hot, it may not feel swollen, but there is something in your body that is micro-inflamed. And that happens a lot in patients with autoimmune disease. because they're attacking their own body. So first off, they're sending all of the attack antibodies, which is part of inflammation. And secondly, when they get where they're going, they're going to attack your body, which is going to cause more inflammation, causing more C-reactive protein. And that doesn't happen in Parkinson's disease either. So at this moment, we don't think so. Tomorrow, we may find that there is a second form of autoimmune disease. I am more comfortable saying I don't think we're gonna find that, but it's not that I don't believe that your body can attack itself. I know it can. I've watched it happen in my patients. It's because we're not finding any evidence of even microinflammation above what the normal population would have.
I heard about, Parkinson's when I had autoimmune. I didn't think it was fixable, but unless I was taking my medication for it. But I was told I would never be cured of it. Stress could be a problem. But then I saw a list and I thought Parkinson's showed up on that list. That was probably about 10 years ago. So
I think I can tell, what she said was, she was doing true legitimate literature searches, not, dear Dr. Google, what do you think? That's not research. What she was doing was reading the manuscripts, the primary literature, about a different autoimmune condition. And someone had created a list of the things, and I think I created a list of things that might be autoimmune. And she believed that she read Parkinson's. You did. But what you read was Parkinson's-like movements, which happen as side effects of antipsychotic drugs. And they happen as the result of us trying to manipulate your immune system outside your brain, and if we use the wrong drug, it gets into your brain, and then you get all the Parkinson's-like movements. So you actually did read that. It was just referring to what the symptoms look like, not where they come from. Does that make sense?
yes,
Yeah,
like that, it's gonna help treat the symptoms, but not the.
right, right. Yes, sir.
Can you address any vitamins, minerals, supplements, or medicines that you should not take with carbon or what is it that's okay to take?
What can I tell you about drug to drug interactions, drug to supplement interactions, those sorts of things? If you are currently on a regimen that contains carbidopa and levodopa, well, some of them are timing issues, right? I don't want you to take any of those supplements that are high protein, right? The creatines, the muscle mass boosters, the I need to feel full quickly to try to lose weight. I don't want you to do any of those within 2 hours of your oral dose of carbidopa levodopa. And that is absolutely that very first reaction that we talked about. Are there other vitamins or minerals that may pose a problem? Just a second. I don't think so. Do pay attention when you have a blood draw, like once a year when they do check all your electrolytes and check and make sure you don't have anemia and magnesium. If that changes and you have Parkinson's disease, you can have some really significant constipation faster than you can imagine. So do make sure that they are watching your magnesium levels. For whatever reason, and I'm not saying it's carbidopa levodopa, I'm just saying that for whatever reason, when that starts to fall, patients with existing Parkinson's disease, their symptoms of hypomagnesemia, magnesium too low, come up really quickly. I am not recommending that you go out and just supplement it. I'm only saying make sure you pay attention to those numbers. Are there other drugs? Certainly, if we need to begin to treat any form of dementia, those drugs are going to cause the symptoms that this lady read about. And so then I need to get involved and figure out what's going on and what's the best for. But to say to you, avoid that, I'm not gonna, why would I? That's like telling a surgeon which hand to hold the scalpel in, right? That's not what I do. And I don't want you to have to worry about 2 prescription drugs. That's what my profession exists for. We exist to say, okay, let's look at this closely before we do something else. The current one that's causing us a bit of a challenge is the drug called Abilify. We add it on to antidepressants frequently, and it can cause some fine muscle movements that look a whole lot like the symptoms of Parkinson's disease. And when I let that happen, now suddenly I don't know which is causing what. And so we get really careful with those. But that's not something that you could stumble into, right? That somebody would have to write the prescription without thinking about it, and then somebody else would have to fill that prescription without thinking about it. And I think most of us are better than that. Was there a combination?
No, that's generically thinking about, it's trying to find out what you should take, what you shouldn't take, what you avoid if you got a cold, what you take if you have a cold.
Allergies too.
I suspect that you probably know the answer for you, right? If I said to you, which product to treat runny nose works the best for you, you would be able to give me an answer. Oh yeah, when I get a really bad runny nose, I use fill in the blank, Flonase nasal spray. Oh no. When he gets a bad runny nose, he uses Benadryl. And this one back here is gonna say, no. When I get a runny nose, I use Claritin. And somebody else is gonna say, when I get a runny nose, I use that vacuum thing where I blow salt water in this nostril and suck it out this one. And every one of you is correct. And that is treating allergies or runny nose or drippy eyes. I can't think of a thing you could pick that would get in the way of your therapy. Knowing that they all have side effects, right? The Benadryl person's gonna get really tired. The nasal spray person, as we get closer to winter and we lose humidity, it's more likely to cause a nosebleed. The Claritin people are gonna have that challenge in that it changes, it gives you that weird metallic taste, especially when you are dealing with high protein products. So suddenly your hamburger tastes funny. And the nose sucker person, if you can stand that, then I get that drowning feeling. I'm like, no, I'm not doing this. And remember, you're really supposed to use distilled water. We had those folks in Louisiana who died from using severely contaminated water. They blew it into their nose and whatever that worm was got into their brain and they're gone. So, make sure that you're doing things correctly, but none of those change your condition. if you have some symptom that you don't remember the last time, I don't remember the last time I got poison ivy, then just go ask your pharmacist. Because every prescription filled in or delivered to Nebraska by law has to get reported to our prescription drug monitoring program. So I can go look and see what you are taking. If you tell me, hey, I take a few prescriptions, will you go look and make sure this is okay? And I can pull that up in just a little under a minute. And then I can see everything that you've done in the last, it will sort for me. I can pick the last month, the last 6 months, or the last 3 years. If I need to go back further, that may take me 4 minutes, but not more than that.
What if you wanna find out when you were talking about like your magnesium?
Uh-huh.
Like I know people that, have trouble with like constipation. Would you tell your doctor about it? Pay attention?
Absolutely, absolutely. And most physicians now are asking, please do your blood work like a day or two before you come to your office appointment. So when you go do your blood work, even before you see your physician, say to the person in the lab, and you are testing magnesium, right? Because tomorrow or Thursday or whenever I see my doctor, I am going to say to them, I'm having a serious problem with constipation. So I need him to have that number when we chat. And for the lab, it doesn't take extra blood. They may even actually have the number and just not report it if nobody asked them for it. So yeah, you can absolutely say, I want to know, I'm curious, show me. Yeah, you certainly can. Yes,
No, drugs, so they don't really have medication.
I'm sorry, try that again.
If you don't go to Roxel, the Roxel.
And Robinson,
Right, okay. And what would you like to?
instead of say, I'll get out of it. And, medication that's for indigestion and, cost presence.
Oh, I see what you're. Since we are talking about. It is not a primary drug, right? So something wasn't going well before we added and brought, right? And that means that it is so personalized that I'm not certain that I'm really comfortable answering the question without a whole lot more, I want to read your whole med profile before I'm comfortable saying, oh, I believe that this is causing that. However, that particular drug has a fabulous, and I mean fabulous, website. And if you type in the name of the drug in your search engine, type in Abrazo and then say approved site, SITE. The site maintained by the manufacturer will then come up. And it will give you 2 boxes. I am a patient or a caregiver, or I am a healthcare provider. Click the patient button first. Read what it has to tell you, and if that doesn't answer your question, then click the back arrow twice, and you'll get the boxes again, and then say, yes, I'm a healthcare provider. That's not true. So what? There's no law that says you can't lie on the internet. God knows that there's somebody in Nigeria right now who knows your great aunt. And if only you send them your bank account number, they're gonna, right? So people lie on the internet all the time. I'm just saying use the patient website first, because that's the one that is built to talk to patients and caregivers. But if it doesn't give you all the information you want, then say, yes, I'm a healthcare provider. It will be phrased differently. It will be laid out differently, but you can find extra information. Does that help? Because then you can see if it is a side effect that is not common, it will still show up in the I am a healthcare professional side. And I would be more comfortable with that approach than with answering, than with answering slightly inaccurately, because you deserve better than that from me. And I don't know that I know enough to answer correctly. Sir, you had a question?
Yeah,
We have a problem with orthostatic hypotension and carbidopa levodopa. Is there anything we can do?
The question was that the patient has progressed to a dose of carbidopa levodopa that is now causing what we call orthostatic hypotension. And that means when you are sitting down or when you are laying down and you suddenly become upright. What we want is that the blood vessels in your hands and the blood vessels in your lower legs will constrict and force the blood up so that it stays in your brain so that you don't get dizzy and faint. And we can tell that that happens by taking your blood pressure when you are lying down, and then it's the minute you stand up, taking it again, and we can watch it drop. Sometimes for a minute, sometimes for 10 minutes. And then the question, of course, is, ew, I don't like this. What can we do about it? Well, we can do a lot of things, but none of them is perfect. So the first thing that we're going to say is, turn your phone off when you go to bed. And you're like, what? Well, if the phone rings and you jump up to answer it, that is when you are most likely to fall. So just turn it off. There is nothing that urgent, really, nothing. And I mean, if it was a severe crisis, it'll be a crisis when you wake up too. Then you're probably not gonna go fix it. The second thing is, remember that every time you stand up or sit up from lying down, make sure you've got something to hold on to. So that if you get that dizzy, even just for a second, you can grab it. My fear is the fall. We have a drug that actually intentionally contains a salt-like product, knowing that salt will hold fluid in your bloodstream. Holding fluid in your bloodstream raises your blood pressure. So I can raise your blood pressure on purpose to stop it from getting too low in those moments when taking carbidopa levodopa would lead to orthostatic hypotension. The catch, of course, is the drug doesn't just work when you stand up and sit up. The drug works all the time. So if I am going to choose to do that, I have to be sure that I can afford to raise your blood pressure that much. And it's not just your heart that I'm worried about. I also am pretty concerned about your kidneys. Because what I'm gonna do is I'm gonna give you a drug that looks like salt that your kidneys can't process, so that I can keep more water in your bloodstream, so that I can keep your blood pressure up. We certainly, if you are going on a bus trip and you know that you're gonna be seated for a long time and you are not in charge of when you stop and get out and walk around, compression hose are wonderful. You can either use knee-high or thigh-high, depending on what's the most comfortable for you, because you're gonna be sitting. The same would be true if you're gonna get on an airplane. Because just getting on the airplane changes your blood pressure. And then we're gonna add to it that you've been seated for an hour or 7 hours or 13 hours or whatever. When you stand up, your blood pressure is clearly gonna drop. So we're gonna use some compression stockings. And there are compression products that runners use. You would maybe call them tights or leggings. But certainly if you're gonna be up and down in a car, on a bus, on a train, in a plane, those kinds of things. And when we're moving in toward winter, they're warm. And so that is an added benefit. Not only will it help with your blood pressure, but it will also keep you a little bit warm. And walking whenever possible, I understand it's not the easiest thing in your life. But the more you walk, the stronger those muscles are. So even if your blood vessels don't respond exactly like we want them to, your ambulatory muscles will help keep your blood pressure up also. But yeah, we can give you a couple of different drugs if we have together decided that it's worth the risk of raising your blood pressure a little bit.
Find balance.
I know, and there may not, we are asking to balance when that's not, it's not as easy as saying, oh yeah, just put 5 pounds over here and put 1 pounds over there, and it sadly, it doesn't work that way. And it's because we can't work exactly the same place as the carbidopa levodopa. So we try to find a secondary pathway to stop the problem. Because you're right, I mean, the alternative is we can just reduce the dose of your Cytomed. That's not gonna make you very happy either. So there we are. Thank you for inviting me. I am sorry, but I'm not, I mean, it's her birthday party. And so I am gonna go have that piece of cake and hope that maybe they didn't sing yet. And thank you very much for inviting me.
Yes, we are so fortunate to have you here today. Thank you so much. Before you leave, you may want to grab a cookie and case the cakes some.
Or not.
Or not. And I'm sure if they've already done a song, you can.
Yeah, I can. I probably will.
But again, thank you so much.
Absolutely.
Thank you. Well, I'd like to welcome you today. We're happy to have you, and our Zoom folks, we're happy to have them too. And of course, Dr. Alex Roundtree, we're always happy to have her. Are Bruce and Cheryl MacArthur here?
No.
Okay, thanks, you know. The Bruce has volunteered to be a treasurer. Clyde Johnson is retiring. And Bruce and Cheryl has volunteered to help over at the table. Also, I'd like to report that I got an email from Mindy Marshman, and her mother had Parkinson's for about 20 years and recently graduated in August, I believe. And they wanted to make a donation to our group. And they were certainly appreciative of that. I don't know exactly where she lived, but the daughter said she either had to go to Omaha or Fairbury and someplace else. And that if she had lived closer, that she would have been an active part in this group. So it was very nice for her family to think of us and to make a memorial. Anyone going to the symposium on Wednesday? All right, look at that. I thought to know that the Lincolnites are here, there. Sally also has brochures and business cards for us to give out. Some of you have been doing that. We'd like to get these brochures out to as many places as we can to let people know about our group. We know there are a lot of people out there who are not involved because they don't know. So I have some in my car and they're good at getting them out. So.
There's some on the table here too.
Okay, so on the table, that business cards and brochures. Any other announcements? Carly has one.
Are we back experience here? No, that's okay. Well, I just wanted to give a backwards parents, and no, she did such an amazing job in Washington DC. So kudos to her, just incredible. I just wanted to personally tell you that. So we went to Washington DC on behalf of the Parkinson's Foundation and Michael J. Fox, and just wanted to share with you all that those meetings with the congressmen and congresswomen and staffers went extremely well. The items that we advocated for, big one was research dollars. So that was huge. Second one was there was an act to end Parkinson's that passed in 2024, which is a huge win for us. Part of that act is there's an advisory council that has to be federally appointed to be able to spend these millions of dollars. And so part of that request was to get people in those seats and kind of expedite that process so that advisory can start putting that money in the best places that it can go. And then the third and fourth was, I talked about this quite a bit, but is advocating to ban paraquat, which is a chemical that many agriculture people use, and as well as golf courses. We've talked about that before, but it's banned in 75 countries. And even China, who we buy it from, bans this chemical. So we talked to them about that to really advocate for their environmental support to ban that chemical. And then the last one was just sharing a little bit of the story. So I don't know if anybody knows any young veterans that are now diagnosed with Parkinson's, but correlating that to what they call burn pits that they used in some of the tours, where they would burn really everything, not just your garbage, but batteries, plastic, like everything that they were done with went in these huge pits and they burned them, and a lot of those soldiers now are getting Parkinson's. So that was just something that, again, we advocated for us to stop doing that. So those meetings went extremely well, and proud parents here of Amy, but Amy organized this whole conference, and there was 275 people there from 47 different states. So it was really incredible. The Michael J. Fox Foundation is doing an incredible job of research. Lonnie Muhammad Ali's wife was there speaking about Muhammad Ali's organization and the great work that they're doing for Parkinson's. And And then the other organization that was there, was a really big sponsor, was the Lewy Body Association. So a fantastic event, so we'll see what's happens, but the advocacy went really well.
You know, about that paraglot, all these countries that have banned paraglot have a decrease in Parkinson's. So, I think that's one of the reasons we really need to fight to get that paraglot out of our lives. Thanks, thanks for, thanks Gunter for zooming and, Sally for the refreshments and Jim for the laundry material and man for the table. And now we're going to divide them into groups. Those with Parkinson's will stay in this room. The caregivers will be in the kitchen. And thanks to Sally, there's some treats over there. So we hope to see, next month, I should tell you, next month, Joe Greenwald from Medtronic is coming and talking about the updates with the DBS. I think that'll be real interesting. So, hope to see you.